Morning students. This topic RH isoimmunization. What do you mean by isoimmunization? Isoimmunization or alloimmunization is defined as a production of immune antibodies in an individual response to foreign red cell antigen derived from another individual species. The first one lacks the antigen. Here, RH isoimmunization the antibody the RH antigen. If the lady is Rh negative, so that means lacking the antigen Rh, and when she is exposed to the Rh antigen, she produces the Rh antibody against it. That is alloimmunization. The other individual from where the antigen is same species. Bit about the history. In 1940, Landsteiner and Steiner identified the Rh antigen, that is rhesus factor, present in blood from a rhesus monkey. It's the production of antibody when injected into rabbits. So, Levin discovered Rh antibody in Rh negative resulted in baby or stillbirth. So, they saw when the baby was affected with hemolytic disease, then they found some Rh antibody against the Rh antigen, and this antigen, this unknown at that time it was unknown, and this antigen was also found in the blood of a rhesus monkey, so it was named as Rh antigen. The rhesus factor is common to rhesus monkey, and those that lack this factor are Rh. And if this Rh antigen is positive, then that individual is Rh positive. So coming to incidence of Rh negative, it is different in different geographical areas. In Caucasians, it is percent population of Rh negative. African 7 to, and in India it is 5 to 10%. North India it is 10%, whereas in South India 5%. The genetic locus for Rh antigen is the short arm of chromosome number 1. What is this Rh antigen? Rh antigen are lipoproteins and they are confined to red cell membrane. Rh blood group system consists of about 50 defined blood group antigens, among which the 5 antigens capital D, capital C, small c, capital E, small e. 5 are the most important. And again, among these 5, the D antigen is the most potent immunogen. So, most of the hemolytic disease Rh blood group incompatibility are because D antigen dominant. Rh positive person can be heterozygous or homozygous. About 65% are homozygous. Homozygous means they will have capital D, that is capital D, capital D. So both the genes are dominant. Whereas in heterozygous, which comprises 35%, one capital D and one small d. That means only one is D antigen in one locus present. But as the D is dominant, if it is capital D, that is Rh positive. What is maternal isoimmunization? Among the antigens capable of causing maternal alloimmunization and fetal hemolytic disease, the Rh blood groups are the most common. So, in particular, as I told, D antigen of the Rh blood groups is responsible. What is the pathophysiology? Alloimmunisation mechanism is when an Rh negative pregnant Rh red blood cells. How the Rh negative Rh positive fetal blood cells? Either during the pregnancy or during the delivery, or when a Rh negative male receives Rh positive blood transfusion. These are the ways how the Rh negative can get exposed to Rh positive red blood cells, and then there will be production of antibodies. This antibody production stages. First stage is sensitization. Second stage is immunization. So when the lady gets exposed to Rh positive blood, there will be sensitization there will be production of very minimal amount of antibody. But when she gets same antigen on a later period, there will be production of antibody, that is in the second stage immunization. It happens, such positive fetal cells enter maternal and remain in the circulation their lifespan over. As you know, the RS blood cells normal average lifespan is 120 days. Life, for them, their lifespan they will be there in the circulation, and then these red blood cells reticuloendothelial system. After they are destroyed in the reticular system, there will be liberation of antigen D. This antigen triggers the RBC antigen antibody M. First, as you know, that first the IgM and later on the immunoglobulin G. Similarly, here also the D antigen creates the antibody M. On subsequent exposure to the same antigen, previously primed B cells now produce globulin G, a small molecule, and can cross the placenta, and this can coat the D positive red blood cells, agglutinates the fetal red blood cells, and can cause the hemolysis. Then this fetal RBC hemolysis occurs in the spleen. An isoimmunization takes almost 10 to 16 weeks. It takes time. It is not like ABO incompatibility where there are already the antibodies are there in the body, and when in incompatible blood is given, there will be reaction. But here the isoimmunization time it takes 10 to 16. That's why usually the first pregnancy is not affected. But in some cases, what we say grandmother's theory. There, the blood cells are transmitted to the Rh positive. The mother is Rh positive, Rh negative. Rh positive will enter into the baby, and the baby will produce the antibody, and it will be there in her body. And when she gets pregnant, in the first pregnancy, the baby can get affected. So the baby is getting that hemolysis from the antibody because of the antigens which are transmitted to her mother from her grandmother. That is called grandmother theory. Otherwise, usually the first pregnancy is not affected. Pre-exposure to the antigen produces rapid immunological response, and it is days. Once it is sensitized on re-exposure, there will be rapid production. The frequency and volume of spontaneous increases advancing pregnancy. So, the fetomaternal hemorrhage in third trimester in compared to the first trimester, and maximum during the delivery. What are the potential sensitizing events? That means which conditions there will be miscarriage. Conditions like when there is any miscarriage, whether it is for medical termination or spontaneous pregnancy, or is there is any antepartum hemorrhage like abruption of placenta PV. They are doing termination of pregnancy for any ectopic pregnancy, hydrative for more, stillbirth, any invasive in utero procedure like amniocentesis, embryonic sampling, or any maternal abdominal trauma, external cephalic version, and manual removal of placenta, cesarean section, or the increased hemorrhage. What are the factors influencing the alloimmunization? That 100% of Rh negative antibody they are exposed to the Rh positive blood cells. 16% of them produce the antibody. Then why it is like that? Why 100% of them are not producing the antibody? Because it depends on certain factors. Depends on the first of all, it depends on the volume of fetal blood and the maternal circulation. Because at least 1 ml blood, uh, it has to if at least 0.1 ml of blood is entered into the maternal, then it can produce the antibody. The second thing is there is inborn ability or sometimes there is inborn inability to RH. The, the woman is non-responder to the RH antigen. Yes, then their own antibody. Some are hyper-responders, some are non-responders, like that. So depending on of the woman, there will be production of the antibody. Then the next maternal fetal abio incompatibility. Actually, this abio incompatibility protective against the alloimmunization, because as the antibody against the cases of abio incompatibility, the antibody is present in, and when you are transfusing abio incompatible blood, there will be immediate destruction of that fetal blood cells, because there are antibodies against the blood cells, because there was incompatibility. That blood cells will be destroyed, fetal blood cells will be destroyed, and there won't be any release of T antigen and no antibody production against Rh antigen. So, abio incompatibility factor against the alloimmunization. The next thing is maternal immune response to antigen. The immune higher, then there will be more production of antibody antigen. Then the other thing it depends on is father's Rh status, zygosity. The father is negative, the mother is also Rh negative. Obviously, the baby will be Rh negative. There won't be antigen. And again, the Rh status of the father, if it is Rh positive, again it may be heterozygous or homozygous. Father is homozygous, capital, then obviously 100% of the children will be affected with the Rh antigens, because they will be all the children Rh positive. Father is heterozygous, then one capital, one small d, percent of the children positive. So we father's status and also the zygosity. What are the types of antibodies produced? Antigen. The two types of antibodies are produced, M and immunoglobulin. The immunoglobulin M is the first to large molecule, cannot pass through, don't cause any harm. However, the second phase is in sensitization IgM produced, but later on in immunization there will be production of, which is a small molecule and which can cross the placenta. And so what will happen to the baby by the Rh antibody? Antibody does not have any effect, but if the fetus, these antibodies get attached to the antigen Rh, there will be destruction of the fetal red cell, and that will be the fetal. This fetal negative can manifest phase. In mild case, can present with congenital anemia, newborn, then erythroblastosis fetalis, Icterus, Gravis. Fetal anemia, the baby have anemia from birth, because there is rapid destruction of the fetal red cell, as there is hemolysis. Then because there is hemolysis, there will be extramedullary devices, enlargement of the liver and spleen to produce the red blood cells, reticulocyte count. The liver, spleen are enlarged, that is called fetalis. Then is Gravis Neonatorum. Because in severe cases, death. The most serious form of hemolytic disease of fetus and newborn is the Hydrops fetalis. Why this fetalis happens and how it happens? Because there is rapid destruction of, there will be severe anemia, which tissue anoxia. Because of the tissue anoxia, there will be metabolic acidosis, and there will be hyperplasia of placenta, because the body will try to transfer more oxygen through the placenta to the baby. So there will be hyperplacenta. And because of the hypoxia, there will be damage to the liver, and as you know, the proteins are produced in the liver, there will be hypoproteinemia. And because of this hypoproteinemia, there will be generalized edema, ascites, and hydrotherapy. It is called hydrops. Where there is collection of the fluid under the skin, liver, the peritoneal cavity, the thorax, everywhere there is the fluid because of the hypoproteinemia. The intravascular fluid comes out to the face. Fluid collection everywhere. Sometimes there may be fetal death because of cardiac failure. How will you diagnose hydrops fetalis? And so the mother will be here Rh negative mother, and if you do serology, get Rh antibody. There will be excessive sugar, that is polyhydramnios, and if you do sonography, there will be edema in the skin, edema in the scalp, that is collection, and pleural effusion, pericardial effusion, and the baby will be in a Buddha position. Here halo around the scalp because of the fluid collection. Here halo around scalp, that is called Buddha position, and the baby looks pale and at birth because as you know there is anemia, so baby will be pale, and because of the collection matters. Similarly, the placenta will also be large, pale, edematic. The placenta. Coming to Icterus gravis neonatorum. Here there is no jaundice at birth, but the baby soon develops in 24 hours of birth. The baby will develop jaundice. Why it happens? In utero, though there is destruction of blood cells there and unconjugated bilirubin reached, that bilirubin gets excreted placenta, and some of the bilirubin passed into the amniotic skin also. But what happens after birth? When cord is clamped, this bilirubin concentration increases because now there is no more placenta or amniotic fluid. Now this to be metabolized in the liver, and here most often the baby will premature baby. Liver is also damaged because of the anorexia. So the bilirubin can't be excreted. So the bilirubin concentration is in this, the baby will present with jaundice. If this bilirubin level rises to a critical level of 20 milligram per 100 ml, then this bilirubin will cross the blood-brain barrier and it will get deposited in the basal nuclei and damage the vessel. And when there is damage of that will result in kernicterus. Kernicterus, there will be and all central damage here. What will be the effect on the mother if there is isoimmunization? There will be increased chances of preeclampsia, polyhydramnios, and big baby. Also, there will be postpartum hemorrhage because the big baby, big placenta. So after the hemorrhage, and also the syndrome. What is similarly as the baby is like edema, the mother will also matters. Generalized edema will be there will be proteinuria and pruritus. How to prevent this Rh? There are three ways. First thing, we have to prevent the active immunization. If the Rh antigen has entered into the pregnant blood and the production of antibody against antigen by giving uh, and RHT immunoglobulin prevent that. The production of antibody destroying the antigen, that is preventing the active immunization. Second thing we can do is we can minimize the fetomaternal feed because more is the fetomaternal feed, more is the production of RHT immunoglobulin. So we have to take certain measures to minimize the fetomaternal feed. And the other thing we can do is avoid mismatched transfusion. Any woman before menopause should not be given mismatched transfusion. That is Rh positive blood should not be Rh negative men. To prevent the active can do it. Rh anti-T immunoglobulin is given intramuscularly in the gluteal region in 72 hours of abortion. If you can give, then it is better. Because if you give it late, we can give it till 28 days, but the effectiveness will be reduced because already the antibody is produced. So it is best to give 70. If the and it Rh anti-globulin should be given if the baby is Rh positive. So as soon as send the cord blood for Rh positive direct. The baby is Rh negative, there is no need of giving anti-D. If the baby is Rh positive and the direct negative, the direct just shows the antibody. If already the antibodies, then there is no use in Rh anti-D. Direct just to show that there is no production of antibodies. This anti-D after delivery reduces the alloimmunization by 90%. What happens to the 10%? Why the next 10% alloimmunization still can happen? Because there may be antepartum fetomaternal bleed and that can cause production of antibodies. So to use that, we can give anti-D at the 8 weeks, further reducing the chances of alloimmunization 0.1%. What is the dose of anti-D immunoglobulin? The pregnancy beyond 12 weeks, 300 microgram, and if the pregnancy is less than 12 weeks, microgram of. Next is we have to minimize the fetomaternal bleed. Then we do that by taking certain precautions. During cesarean section, spillage of blood to the peritoneal cavity. And next thing we can do no routine manual removal of the placenta. So manual removal of placenta, there will be more chances of fetomaternal bleed. So we should wait for the spontaneous expulsion of the placenta in the cesarean. Avoid the prophylactic ergometrin, part of hemorrhage. We use the ergometrin. Avoid this ergometrin either during cesarean or normal delivery because this ergometrin is fetomaternal. And when we are doing any procedure like amniocentesis, do it under ultrasound guidance so that necessary go into other places and there will be more failure rates if you are not guidance. You have to so to avoid that ultrasound guidance. Avoid the forcible person under general anesthesia. If you are taking general anesthesia, the patient will complain any and we will be forcible external, then there will be more chances of fetomaternal. So and not do routine manual removal of placenta, and even if you doing if necessary, then very gentle placenta. And how to manage? So we have to divide the two groups. Rh negative non-isoimmunised, that means there is no antibody in the body, and the other thing is isoimmunized, already antibody. So first thing is Rh negative non-isoimmunized. First we should when we Rh negative when he has already antibodies Rh phenotype of father. The father is Rh. Then we can manage the pregnancy like a normal pregnancy. If the father is positive, then we have to do genotype, whether homozygous or heterozygous, to know whether all the babies will be affected or 50%. So if heterozygous, then all babies will be affected, then we can determine the baby's blood group by doing either or some prenatal test. We can take the cell-free DNA at around 9 weeks of pregnancy. We can determine the baby's blood group because if the father is at 2% of can be Rh negative. Necessarily interventions baby is Rh negative. That's why if the father is Rh positive and heterozygous, it is important to the genotype of baby. How to detect the Rh alloimmunization? Rh sensitization for delivery 1% of antenatal. Identify antepartum sensitization. Antibody dead. So anyhow, all ladies are doing cooking visit and 12 weeks that we do blood grouping typing. Then again we should repeat the test at around 28 and 36 primary Gravis. Yes, the test should be at month every primary at booking and monthly after that for antibody. Then the patient can be given at 28 weeks of 300 at 28 weeks that will allow me the antibody. Then again we have postpartum and 70 and 30. Next coming to Rh negative isoimmunized. That means there is antibodies are there. Here also again we have to detect paternal Rh, right? The father is Rh negative. To further test. Father is Rh positive, then again full genotype whether the father is homozygous or heterozygous. How can we do the fetal Rh determination? Rh determination. The phenotype can be determined by testing blood, and the genotype can be done by CBS or amniocentesis. But these are in now the non-invasive fetal Rh can be performed by using cell-free fetal DNA and then cell-free analyze determine the Rh typing of babies. There is no doing the invasive test like CVS and amniocentesis because these procedures have certain reasons. If the pregnancy is positive anti-D, the titer is greater than 1:2, that is Rh alloimmunization. The antibody titer is 1 is not needed if the titer is up to 1:8. But after that, after this, but the varies. Others take after that we have some intervention. Why we will assess? Now you know there is antibody already produced antibodies there in the pregnancy. So we will do the fetal assessment for two purposes. First thing is we have to detect anemia prior to the occurrence of the fetal compromise. There is anemia. Our goal is to fetal morbidity mortality. So how to assess the severity of the fetal? Now you know that anemia. So how to assess the severity? You can do it with ultrasound to establish the correct gestation. You can monitor the, we can detect the fetal hydrops, we can guide the invasive procedure like amniotic and Cordocentesis sampling. If there is fetal hydrops, there will be edema, scalp edema, skin edema, peripheral effusion, pleural effusion, the position. All this will lead to the diagnosis of fetal hydrops. And also we can do middle cerebral artery peak systolic velocity. It is the best tool for predicting the fetal anemia in who is at risk pregnancy. Pregnancy, take the fetal anemia, PS. What is the principle here? In anemic fetus preserves the oxygen delivery to the brain by increasing the cerebral blood flow. So last thing, the blood flow to the brain. So the baby try to increase the blood flow to the brain to supply oxygen. So even if the blood flow is reduced in other organs, the brain will have maximum amount of blood flow, called brain sparing effect. The peak the systolic velocity of cerebral artery. We have to do this velocity by doing the Doppler. When this PSB is more than 1.5 multiples of median, that suggests there is moderate to severe baby. Baby is already affected here. 1.5 multiple median. The mainstay fetal surveillance in red cell immunization, because this is easy to do and non-invasive. The other methods we can use are ultrasound is non-invasive, but now other methods we can invasive evaluation of severe, indirect and direct method. Here we have to do some invasive method. Indirect method, what we do to obtain the amniotic, the ultrasound guided amniocentesis. Then we do the spectrophotometric analysis of amniotic. Because there is hemolysis, there will be amount of amniotic fluid. So we can do the spectrophotometric analysis of the amniotic fluid. And in direct method, blood are done using sample obtained by the directly blood from the cord, umbilical cord, cordocentesis. And then we analyze the fetal blood for hemoglobin, reticulocyte count, and fetal blood sample. The amniotic fluid analysis, what we do, the amniocentesis and this amniotic can be, then we can use lung lecithin surfactant baby need delivery lung maturity by studying amniotic fluid. And then is the spectrophotometric analysis. The amniotic and this performed physical titre, or there is the C affected test. How to do the spectral optical density of amniotic will be between 700 wavelength in presence of bulge at 450 nanometer. And then this is plotted in a chart that is called LiLey chart 7 to this delta density at 4 x-axis station in, whereas the y-axis the optical at 4. Chart has low, mid, and high zone. Delta optical density high zone 1, that means lowest zone, and there is very low risk of severe fetal anemia. Wait for delivery. Terminate the pregnancy. Then just surveillance. That is middle. There is mild to moderate fetal. Here we have to expect subdominal after, and we have to surveillance. And high probability 7 to 10 days for the baby salvageable and delivery baby. If it is in the low zone, we can deliver at term, but it needs regular ultrasound like NH, biophysical profile, and Dopplers. It is in the high, mid, and low synthesis, as I told, sampling. And from this, that blood acid, platelets, reticulocytes, and fetal transfusion. Third, here in high zone, baby delivered at around effective. After giving birth, it is better section and free from baby section. Coming to Cordocentesis, ultrasound guided fetal blood sample that will be taken from the umbilical cord under guidance. It helps to detect the fetal blood group, direct site count, blood sample. The indication when you have done the ultrasound, done the Doppler, and there you have got middle cerebellarity high medium. There the baby compromised and there is brain sparing effect. The blood is the brain other organs. That's why the velocity is increased. Or if you have seen fetal hydra or the hemoglobin have done other test and that again how to deliver, when to deliver. Unimmunized mother wait till then terminate. But here we should not allow the pregnant woman to cross the delivery. Expect if the mother is immunized, decision of delivery depends on the severity. Baby affected depends on child case around 37 8 weeks. Your case you have to deliver after or if there is any sudden rise titre or high titer, just or MCA has been 5 months. To care during delivery, prophylactic ergometric active method as it increases. Avoid spillage of blood into the peritoneal cavity during sex. You have to avoid routine manual placenta because this is the cord clamping, cord clamp, and which cord long around first transfusion of the blood if the baby is severely affected, then and the baby 30 age severely affected, some the intrauterine transfusion. This will correct the fetal anemia, the fetal hepatic function. Can be done either or intravascular. The other thing is you can do also change transfusion. One intravascular vascular. After the delivery, the indication RH direct positive and the cord blood will be 7 gram per day or total or more exchange transfusion. Here 80 to blood and the root pain. The RH depends on the type of the maternal antibody of previous baby. Like all this decides the prognosis. With the use of interventions, fetal amniotic, all this is the intent and coming there is no contract breastfeeding.